Hello everybody, this is Dr. Nadeem. We are with Neuromyelitis lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. You can join the channel, you can subscribe the channel. We also have a Telegram group which you can join the group, which is very good for accessing all lecture related information. We have a Google Drive where the PDF of all the lectures are available. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we are with Pursue 7V, which is Neuropathology, Demyelinating Diseases. We are streaming from IPGMER, Kolkata. And to talk on today's topic, which is Demyelinating Diseases, Pathogenesis and Pathology, we have Dr. Shristi Butta, who is an MBBS honors and gold medalist, MD in pathology, demonstrator at the Oncopathology unit at the Department of Pathology, IPGMER, SSKM Hospital, Kolkata, with 12 publications in national and international journals, special interest in neuropathology, molecular genetics, and hematopathology. With this, I would request Dr. Shristi Butta, ma'am, please start your lecture on demyelinating diseases, its pathology and pathogenesis. Over to you, Dr. Butta. Thank you so much.
A very good morning. So today we are all set to discuss demyelinating diseases. Now, demyelinating diseases is one of the very important questions, and for postgraduates, it can always come as a short note. Okay, so without much ado, let's start. So what do we plan to discuss today? We plan to discuss about the demyelinating diseases, what are its types, inflammatory demyelinating diseases, multiple sclerosis, yes, it's a most common demyelinating disease, and how is it different from leukodystrophies, viral demyelination, and what is metabolic demyelination, and finally the key takeaways. So let's start. So demyelinating diseases. Now myelin, as we all know, is formed by the oligodendrocytes, right? Once this myelin is lost or chewed up and broken down, it is referred to as demyelinated area, right? So any disease which produces this demyelinated area, okay, with loss of myelin, which is actually produced by the oligodendrocyte, is referred to as a demyelinating disease. So the term demyelination describes the loss of myelin, okay, with relative preservation of the axons. This results from diseases that damage the myelin sheath or the cells that form them, that is the oligodendrocytes, right? So now what do we see in this figure alongside? We see a normal neuron, okay, and what is this yellow thing that you see here? You see the myelin. What about this one? This is a demyelinated neuron in multiple sclerosis, and what do we see here? The gray area. The gray area shows the characteristic damaged myelin, or rather loss of myelin. How is this demyelinating disease different from dysmyelination? Dysmyelination refers to failure to form the myelin normally. That is, there is formation of myelin, however the myelin formation is characteristically abnormal. Okay, so the dysmyelinating disease refers to a disease which is characterized by abnormal formation of myelin, particularly due to genetic mutations, right? Whereas a demyelinating disease is characterized by normal myelin formation, however, this myelin is lost or damaged. And the most common prototype of it is multiple sclerosis, right? Now coming to leukodystrophies. Now leukodystrophy is the prototype of dysmyelination. What is meant by dysmyelination? Dysmyelination is nothing but, what is it? Yes, it is nothing but the abnormal formation of myelin, particularly due to genetic mutations, right? Now, the inherited disorder of the white matter of the central nervous system, which is caused by various mechanisms involving the lipid metabolism, myelin protein, organic acid metabolism, or other mechanisms as well. It involves diseases like the X-linked adrenoleukodystrophy, metachromatic leukodystrophies, okay, globoid leukodystrophy, or we all know as Krabs disease, Alexander's disease, Canavan's disease, etc. So now, demyelinating diseases can be classified. Now, how can they be classified? They can be classified on the basis of their characteristic pathogenesis. Okay. So, demyelinating diseases due to inflammatory process or inflammatory demyelination for that matter. Viral demyelination due to viruses like the JC virus or the polyoma virus or the HIV virus for that matter. Demyelination caused by acquired metabolic derangements like the vitamin B12 deficiencies, okay, or for that matter correction or rapid correction of sodium in cases of hyponatremia resulting in Centralpontine myelinolysis, or the characteristic hypoxic ischemic demyelination or demyelination due to focal compression of tumors, for example the gliomas, okay, that can result in demyelination as well, particularly at the edge of the tumor. Okay, so let's move on and discuss these in details. So now coming to inflammatory demyelination. Now what is the prototype of inflammatory demyelination? The prototype of this disease is multiple sclerosis. Besides multiple sclerosis, what are the other two diseases included in this category? In this category, we also have the acute disseminated encephalomyelitis and the acute hemorrhagic leukoencephalitis. Okay, of which remember multiple sclerosis is typically very important. There are different types of multiple sclerosis that we know. One is the classical, the other is the acute. Then we also know Neuromyelitis Optica and the concentric sclerosis. Okay, so let's move on. Multiple sclerosis. Now, multiple sclerosis is typically very important short note for all the postgraduate trainees. So just a quick overview of it. Multiple sclerosis is broadly considered a CNS demyelinating disorder. As we all know, it belongs to the inflammatory demyelinating disorder category. So there is characteristic chronic inflammation, okay, and neurodegeneration, particularly of the white matter, but now also gray matter has been, yes, it has been found that it also affects the gray matter as well. Now, multiple sclerosis is a chronic immune-mediated inflammatory demyelinating disease. Okay, there is a role of viruses as well that have been implicated, like the Epstein-Barr virus and the human herpes virus, but the basis of it is inflammation. It is autoimmune, genetic or environmental role has also been implicated in this disorder. Okay, it is to be noted that the main characteristic of multiple sclerosis includes inflammatory demyelination, axonal injury, and the development of CNS lesions. Right? So let's move on. So now coming to the pathogenesis of multiple sclerosis. In the pathogenesis, from the pathogenesis perspective, it is important to note that autoimmune infections, genetics, and environmental role has been implicated in the pathogenesis of multiple sclerosis. Now, regarding the autoimmunity, it's been found that multiple sclerosis is a cell-mediated autoimmune disease, okay, directed against the CNS myelin antigens that involves both the CD4 plus and the CD8 plus T cells. In addition, B cells have also been implicated in the pathogenesis of multiple sclerosis, and this will be discussed in just a bit. Coming to the infections, infectious agents play a crucial role by inducing these myelin reactive pathogenic T cells. In addition, genetics, both MHC and the non-MHC genes are the risk factors for the development of multiple sclerosis, and MHC genes determine the immune repertoire, whereas the non-MHC genes determine the regulatory and the tolerance mechanisms, and both of which have been implicated to be defective in multiple sclerosis. It must be noted that the pathogenesis of multiple sclerosis involves the characteristic initiation and perpetuation of the inflammatory mediators, which leads to the characteristic apoptosis of the oligodendrocytes and damage to the myelin sheath of the axons. Right? Now coming to the environmental role, environmental factors can increase the risk of both the development of multiple sclerosis and also the disease course. Okay, environmental factors like lowered vitamin D levels, lowered UV radiation exposure, cigarette smoking, obesity, and Epstein-Barr virus exposure have been implicated. Regarding the B cells, it must be noted that B cells play a central role in multiple sclerosis. Like the T cells, there are pro and anti-inflammatory B cell subsets. In relapsing multiple sclerosis, B cells serve as the primary antigen-presenting cell that drives the pathogenic T cells. In progressive multiple sclerosis, B cells enhance the compartmentalized CNS responses through the lymphoid follicles and secreted factors. Right? So we'll go into the details of it. Now, multiple sclerosis involves the characteristic demyelination, but however, it must be noted that there is also a remyelination that goes hand in hand. Okay? Myelin is as we all know, is very essential for the impulse conduction from one nerve cell to the other. So reduced conduction will result in deficiencies in the sensation, movement, cognition, etc. So remyelination, however, occurs under conditions of demyelination. But these repeated attacks of demyelination followed by remyelination results in the characteristic scar, which is referred to as the plaque. Now this plaque is very important and diagnostic of a multiple sclerosis. Okay. It must be noted that remyelination forms a thin sheath of myelin, as you can make out here. Okay, the myelin sheath is comparatively very thin, and these regions of remyelination can appear as shadow plaques. Okay, they can appear as shadow plaques. Remyelinated plaques are very thin and faint, and therefore any sort of physiological stress can re-exacerbate an old multiple sclerosis lesion, and this is referred to as the characteristic Ut-Hoff's phenomenon. Okay, so this is characteristically referred to as Ut-Hoff's phenomenon. That is the reactivation of the old multiple sclerosis lesion. Okay, because of the destruction of these thin remyelinated plaques. Okay, so the direct injury to the oligodendrocytes and axons have been related to the CD4 plus and CD8 plus T cells, right? In addition, B cell activity and antibody production followed by activation of the microglia and macrophages have also been implicated. There is also an indirect effect of the pro-inflammatory cytokines which are released by these T cells. But how are these T cells activated? It is particularly important to note that the B cells are capable of presenting these myelin peptide antigens to the autoreactive T cells, which results in the characteristic activation and proliferation of these T cells. Okay, so the activation of these T cells results in the characteristic pro-inflammatory cytokine release and a cytokine storm. In addition, it must be noted that the microglia and the macrophages are also activated by these B cells, and that particularly results in characteristic demyelination. Now, lymphocytes gain access to the CNS through the disruption of this blood-brain barrier. Okay, and that presumably results from the inciting factor, which is nothing but the virus. Okay, the virus can be an Epstein-Barr virus or the JC virus or the HIV or etc. Anything. Now, lymphocytes enter the CNS and trigger a characteristic inflammatory response, and there is release of cytokines and chemokines as well. So what are the common presenting features? The common presenting features include weakness, paresthesia, focal neurological deficits, diplopia, optic neuritis, ataxia, vertigo, autonomic motor abnormalities of the bladder, bowel, sexual dysfunctions. Okay, there may also be painful muscle spasms, trigeminal neuralgia, fatigue, depression, subtle cognitive difficulties, psychiatric disturbances, seizures, etc. Okay. Now, the basic pathological feature that is implicated in multiple sclerosis is the characteristic plaque, right? So the classical multiple sclerosis produces a characteristic plaque. Now, what is a plaque? A plaque is nothing but a zone of demyelination. Okay, so in this figure shown alongside, there are 4 images that have been shown, right? Now we are seeing image A. What do we see in the image A? We see a zone of demyelination, okay, but this zone is characterized by ramification of the microglia or the macrophages only. Whereas in the active demyelinating condition, what happens is that this plaque-like area that you can see alongside, okay, in the white matter is characterized by presence of these foamy macrophages or microglia which are actually laden with myelin, producing the characteristic demyelination. What about this one? This is the mixed active-inactive area, and what do you see here? You see the ramified microglia or the macrophages. In addition, you see the foamy macrophages with myelin, and there are some foamy macrophages without myelin. On the other hand, in the inactive state, there is only those macrophages which lack myelin. Okay, so foamy histiocytes or macrophages are present, but these macrophages lack myelin. So what is a plaque? A plaque of demyelination is an area which is present in the cerebral cortex, particularly in the white matter. Okay, periventricular white matter, optic pathways, spinal cord, etc. can be affected. The zone particularly consists of ramification of the macrophages. Okay, and these macrophages or foamy histiocytes may be laden with myelin or without myelin for that matter. Okay, when it does not have any myelin, the plaque is said to be inactive. Okay, however, when there is myelin laden within these macrophages, it results in characteristic demyelination of that area. Okay, and this plaque therefore becomes an active demyelinating plaque. So, if we see the gross picture, okay, the radiological aspect of it, the radiology shows the characteristic periventricular white matter showing you the lesions, periventricular demyelinating lesions here. Okay, when we see the gross pathology of it, the gross pathology shows a characteristic plaque-like area, okay, which under MRI flare sequence is referred to as the periventricular ovoid Dawson's finger. Okay, right here. So these are nothing but the demyelinating plaques of the multiple sclerosis. And what is this plaque? This plaque is composed of the characteristic lymphocytes, okay, and these macrophages which are laden with myelin, right? Okay, so now coming to the pathology of these plaques, what do we see? We see that the active plaques contain a characteristic perivascular inflammatory infiltrate rich in lymphocytes and macrophages. Okay, whereas an inactive plaque is hypocellular and densely gliotic, right? So in this image shown alongside, you see a vessel, and surrounding this vessel are number or numerous lymphocytes that you can make out here. What do you see here in the image down here? We see that there are lots of macrophages here, and all of these macrophages are lipid laden. Okay, so these lipid laden macrophages or myelin laden macrophages for that matter are very characteristic of an active plaque. On the other hand, an inactive plaque will not have this appearance. Okay, it will have macrophages, but the macrophage density will be quite low and the area will be densely gliotic. Okay. Now this is a chronic active plaque. In a chronic active plaque, what do you see? You see a central hypocellular densely gliotic area, and there is a peripheral zone, and this peripheral zone contains the lipid laden macrophages, okay, and with some nuclear debris, okay, as you can make out in both the images A and B here, right? So this is a chronic active plaque. Now what about a shadow plaque? A shadow plaque is a sharply circumscribed area of reduced myelin density. Okay, so there is myelin formation, okay, around this area of demyelination. There is a zone, there is a peripheral zone of remyelination here, okay, and this forms the characteristic shadow plaque, okay, which is nothing but the thinly remyelinated axons. Okay, and what do you see here? You see the characteristic CD68, which has highlighted the numerous macrophages in this demyelinated area. Okay, so there is a zone of demyelination, as you can make out here in this brown area. Okay, there is a zone of demyelination, and that demyelinated area is surrounded by a zone of remyelination, okay, resulting in the characteristic shadow plaque formation. Okay, however, it must be noted that this remyelinated area is very thin. So this thin remyelinated area, okay, can be subjected to subsequent rupture and can result in characteristic old multiple sclerosis re-exacerbation. Okay. Okay, so now what are the other findings of multiple sclerosis? The other findings include the characteristic gliosis. Now, gliosis is typically seen in the inactive plaque area. Okay, so this dense gliosis can be appreciated here, and this has been highlighted by the GFAP, that is the glial fibrillary acidic protein immunohistochemistry. Okay, a combination of different plaques, that is a demyelinating plaque, a remyelinating plaque, or a shadow plaque, together with characteristic chronic active plaques, inactive plaques. That is, a combination of different plaques are characteristic or diagnostic of multiple sclerosis. Now, distinction of a demyelination from the destructive process such as infarction depends largely on the demonstration of axons. So it must be noted that presence of axons within regions of white matter that are devoid of myelin suggests a characteristic demyelination rather than an infarction. So in an infarction, what happens? There is destruction of the axons as well. Okay. So now, what is acute multiple sclerosis or the Marburg type multiple sclerosis? Now, this term has been given to the rare or the fulminant variant of multiple sclerosis. Okay, it is believed to affect children and young adults usually. Some patients diagnosed with this disease have a characteristic aggressive form of acute disseminated encephalomyelitis. This designation may overlap with acute inflammatory demyelinating, presenting as a characteristic space-occupying lesion. Okay, so acute inflammatory demyelination with a space-occupying lesion usually is referred to as a acute multiple sclerosis. Now coming to Neuromyelitis Optica. Now this variant is characterized by the development of optic neuritis and acute transverse myelitis within days, weeks or months. Most patients present with visual loss and develop paraplegia and sensory loss. Neuromyelitis optica is pathogenetically distinct from other variants of multiple sclerosis in that the demyelination is antibody dependent and complement mediated. Okay. Now, during the acute disease process, the CSF contains large number of polymorphonuclear leukocytes. Oligoclonal bands of immunoglobulins are much less often seen in neuromyelitis optica than in other types of multiple sclerosis where you see more of oligoclonal bands. And in many patients, the serum contains autoantibodies with high specificity for the disorder. Now, what is concentric sclerosis? Now, this rare and unmistakable variant of multiple sclerosis is characterized by lesions composed of alternate bands of demyelination and remyelination within the white matter. Okay, similar to the onion bulb that you see in chronic inflammatory demyelinating polyneuropathy, which is a peripheral nerve neuropathy. Okay. So that is very important to note that this multiple sclerosis can also show a characteristic concentric sclerosis type of a pattern with characteristic areas of demyelination and again a remyelination. Okay, with the formation of a concentric ring. Concentric sclerosis often rapidly progresses and the release of mediators of oxidative stress, okay, such as the nitrous oxide, superoxides by macrophages and microglia in the bands of the demyelination, okay, causes a protective preconditioning of the oligodendrocytes in the immediately adjacent area, and that results in the characteristic remyelination. Okay, so this is the histopathological view of it. Okay, and this is the diagrammatic representation. So what do you see here? We see the concentric lamellar appearance or the concentric sclerosis. Okay, seen in multiple sclerosis. There is minimal edema that you can appreciate. Now this is the leading edge of the expanding lesion and this is the one which is producing the hypoxia inducing factors. The central core is basically shows an increased vascular permeability at the site of the venule. And what you see here, these are the rings of demyelination which particularly consists of the macrophages, microglia, and they particularly produce a lot of chemical mediators as well. And that results in the characteristic demyelination. So there are zones of demyelination and remyelination and that produces a characteristic concentric appearance. Now coming to progressive multiple sclerosis. Now progressive multiple sclerosis can develop from the relapsing form of multiple sclerosis, or it can be progressive right from the outset. That it is referred to as a primary progressive multiple sclerosis. Now the pathological feature associated with the progressive multiple sclerosis is basically a brain atrophy, which is related to the axonal loss, cortical demyelination, microglia activation, and failure of remyelination. Note, there is failure of remyelination, and that results in the characteristic progression of the disease. So how does this happen? It can either be immune independent, where you have mitochondrial DNA mutations, and that results in characteristic release of the reactive oxygen species and mitochondrial injury. There may be demyelination resulting in the release of iron and causing oxidative stress. In addition, there may be influx of calcium, and there may be a associated glutamate excitotoxicity, and that can result in the immune independent pathway of brain atrophy and neurodegeneration. It can also happen due to immune dependent mechanisms that involves the characteristic microglia, astrocytes, and the B cells. Okay, and they can drive the disease process, resulting in release of inflammatory mediators, which results in brain atrophy and neurodegeneration. So what is the goal of the therapy? The goal of the therapy is chronic reduction in inflammation. Okay, so there is an associated inflammation, and that needs to be reduced. Augmentation of remyelination, which is very important, because if this remyelination does not happen, it results in the characteristic progressive multiple sclerosis and a suppression of the neurodegenerative process that is happening. Now, what is acute disseminated encephalomyelitis? Now, this inflammatory demyelinating disease mainly affects the children. It typically occurs within 3 weeks of infection, vaccination, or of giving drugs, and is typically thought to be due to T-cell hypersensitivity reaction. The infections like the Mycoplasma pneumoniae, Campylobacter jejuni, group A streptococci, or other bacteria can be few causative agents. Viral causes include measles virus, mumps, varicella zoster, rubella, or infectious mononucleosis. Now, the most prominent clinical feature of this disorder is ataxia, headache, and weakness. Acute disseminated encephalomyelitis, the dissemination basically results from the demyelination, and that is generally confined to a much narrower perivenous or perivenular zone. The lesions are usually bilateral, and although not exactly symmetrical within the cerebral white matter and brainstem, they can also affect the cerebellum and the spinal cord as well. Small veins and venules are characteristically affected in the white matter, and they are surrounded by lymphocytes, macrophages, and plasma cells. A sleeve of adjacent white matter is usually edematous and demyelinated. Okay. Now, what do we see here? We see here a zone of demyelination, which is characterized by perivascular inflammatory infiltrate and numerous foamy histiocytes in the background. Okay, which is densely gliotic background. Okay, so what do you see here? You see numerous inflammatory infiltrate. You also can make out numerous foamy histiocytes, which have been highlighted by the CD68 here. Okay. Now, what is acute hemorrhagic leukoencephalitis? Now, this basically precipitates due to bacterial viral infections, or it may be due to some vaccine exposure. Symptoms include fever, fatigue, headache, nausea, coma, and brain hemorrhage. So the abnormalities of acute hemorrhagic leukoencephalitis is more asymmetrical as compared to acute disseminated encephalomyelitis. Affected areas of the brain are usually edematous and shows a characteristic parenchymal blood vessels with characteristic fibrinoid necrosis. Okay, as you can make out in the figure shown here. Okay, there is fibrinoid necrosis and these are the blood vessels showing a lot of hemorrhage. Okay, and there are zones of demyelination with inflammatory infiltrate and foamy histiocytes. Okay, necrotic debris, with neutrophils and mononuclear inflammatory cells are also seen in the demyelinated area. Now coming to CIDP, or the chronic inflammatory demyelinating polyneuropathy, or the polyradiculoneuropathy. Okay, now this condition will basically be discussed in details when we discuss the nerve biopsies, but for now just highlighting the main points. CIDP is a clinically heterogeneous, symmetric sensory and motor neuropathy of immune origin, mainly motor. Okay, so the classical presentation is a motor neuropathy affecting both the distal and the proximal muscles of the forelimb, along with the sensory involvement. There is generalized areflexia evolving as a monophasic, relapsing or progressive disorder in more than 2 months. Okay, the hallmark is the inflammation mediated demyelination. Now, demyelinating lesions are characteristically distributed in a multifocal pattern in the peripheral nervous system. Okay, the examination of the nerve biopsies serves as a privileged instrument for the diagnostic purposes, and macrophage-mediated demyelination has been described in CIDP as well. Okay, so there is macrophage-mediated demyelination, as has been described in multiple sclerosis. Now, what is the diagnostic hallmark of it? The diagnostic hallmark is the segmental demyelination and remyelination of the peripheral nerve, which results in the characteristic onion bulb formation. Okay, so you see you have a lot of onion bulb formation here that can be made out. In addition, in minority of the cases, there may be endoneural and intramyelinic edema that you can make out here. And there will be characteristic axonal degeneration. Okay, proliferation of the Schwann cells, as you can make out. There is a lot of proliferation of these Schwann cells, okay, which results in the characteristic formation of these onion bulbs. Okay, yeah, fine. Now coming to viral demyelination. Now, viral demyelination, as we all know, is caused by the JC virus. Okay, so progressive multifocal leukoencephalopathy, or PML, is nothing but the lytic infection of the oligodendrocytes caused by the JC virus. Now, the principal viral demyelinating disease of the humans is the PML, and that is caused by the JC virus and the Papova virus. The virus establishes a latent infection in the B cells, kidney, and possibly in the CNS as well. Reactivation occurs under conditions of impaired cell-mediated immunity, for example, after organ transplantation or in patients with HIV or AIDS, leukemia or lymphomas. Patients usually present with an insidious onset of neurological deficits, particularly affecting the motor function, speech, vision, personality, and cognition. So now what do we see in the histopathological aspect of the progressive multifocal leukoencephalopathy? Okay, we can make out the characteristic myelin pallor in the looks all fast blue stain here. Okay, when comparing with the HNE, we can also see that there is increased proliferation of the oligodendrocytes, which have comparatively increased in size as well. Okay. Now this is a normal cortex which is shown in the looks all fast blue, and this shows the characteristic myelin pallor that you can make out under looks all fast blue with proliferation of these oligodendrocytes. You can also make out the proliferating oligodendrocytes in this area, which shows a characteristic distinct demyelination. Note, looks all fast blue is the stain which we use for myelin. Now, it is important to note that why these oligodendrocytes are proliferating. Okay, so when there is an oligodendrocyte loss, okay, due to demyelination, then why are these oligodendrocytes proliferating? This is because there is activation of these oligodendrocyte precursor cells, okay, or the oligodendrocyte progenitor cells. Now, these precursor cells undergo migration, proliferation, and differentiation to form the characteristic myelinating oligodendrocytes, and that causes the characteristic remyelination. So, why does this happen? It has to be noted that the microglia are responsible for the remyelination. That is the beneficial role of these microglia. the microglia or the macrophages, besides clearing the myelin debris, can also secrete factors that can induce the proliferation of the oligodendrocyte precursor cells, and that results in the characteristic migration, proliferation and differentiation of these cells to produce the characteristic oligodendrocytes, and that causes formation of these myelin and results in characteristic remyelination. Okay, so besides the destructive role of these microglia in demyelination, it also helps in remyelination, right? Now, what are the other viral demyelinating diseases? Now, other viral demyelinating diseases besides the JC virus induced PML, there is also HIV-induced demyelinating diseases, which produces characteristic microglial nodules, okay, as you can see in the figure shown here. It also shows a characteristic vacuolar degeneration, which has been highlighted by the Luxol fast blue stain, okay, which has stained the myelin. Okay, so there is very little myelin. There is myelin pallor that you can make out here. Okay, and there is accumulation of these foamy histiocytes in addition to the vacuolar degeneration that you can make out. What do you see here? You see the characteristic multinucleated giant cell encephalitis with surrounding gliosis. Okay, there is also proliferation of these oligodendrocytes that you can make out. Okay, particularly due to the release of the OPC, that is oligodendrocyte precursor cells. Now, coming to subacute sclerosing panencephalitis. Now, this is a disease which is particularly caused by the measles virus, which causes perivascular inflammation and gliosis of the white matter. But what is typically important in measles virus is the intranuclear inclusions that you can make out here. As shown by the arrow, you can make out the intranuclear inclusion body. Okay, though it tends to be sparse, but yes, you can definitely make it out. Now, coming to acquired metabolic demyelination. Now, acquired metabolic demyelination includes two important diseases. One is the Centralpontine myelinolysis, okay, and the other is the vitamin B12 deficiency. Besides that, very rarely demyelination occurs in association with chronic alcoholism. Now, Centralpontine myelinolysis is a monophasic demyelinating disease which particularly affects the pons and the midbrain. Okay, it most often occurs due to rapid correction of the hyponatremia. Another clinical context in which the Centralpontine myelinolysis is increasingly common is in patients with liver transplant in whom high cyclosporin levels have been implicated. The presentation is usually rapid and there is often confusion, limb weakness, okay, spastic tetraparesis and mutism. Centralpontine myelinolysis is a concentrated, often symmetric, okay, non-inflammatory demyelinating disorder which basically affects the central basis pontus. Demyelination also occurs in the extrapontine sites in about 10% of the cases, affecting the midbrain, thalamus, basal nuclei and the cerebellum. So what do you see in this figure? The lesions are sharply demarcated, as you can make out here. Okay, so this is the zone of myelinolysis that has been shown affecting the basis ponti. Okay, here, and during the active disease, it contains lipid-laden macrophages, okay, as we have discussed in multiple sclerosis. So features of demyelination with lipid-laden macrophages and a gliotic background will obviously be present. In addition, there will be perivascular lymphocytic infiltrate. Infiltration of lymphocytes, however, is sparse to absent in this case, okay, but must be noted that axons and neurons are generally well preserved. Now, coming to subacute combined degeneration. Now, this characteristically affects the spinal cord, the lateral and the posterior columns of the spinal cord. It basically results due to deficiency of vitamin B12 and produces characteristic hematological and neurological manifestations. Why? Because vitamin B12 is an active cofactor which is involved in the synthesis of DNA as well as myelin. Okay, subacute combined degeneration of the spinal cord can be caused by inadequate oral intake of vitamin B12 or poor absorption of vitamin B12 or by the use of medications like metformin, proton pump inhibitors and nitrous oxide. Okay, so what do we see here? We see that vitamin B12, okay, can act as a cofactor for two important enzymes. That is, methylcobalamin and adenosylcobalamin are cofactors for enzymes methionine synthase and L-malonyl coenzyme A mutase, okay, as you can make out. Okay, it is important to note that methionine synthase converts homocysteine to methionine when folate, that is 5-methyl tetrahydrofolate, is converted to tetrahydrofolate, and that is required for purine and pyrimidine synthesis, that is DNA synthesis. Okay. In addition, adenosylcobalamin acts as a cofactor for methyl malonyl coenzyme A mutase, and that converts methyl malonyl coenzyme A to succinyl CoA, and that step is very important in myelin synthesis. So any deficiency of vitamin B12 can result in defective myelin synthesis, or rather deficient myelin synthesis. This results in the characteristic subacute degeneration of the spinal cord. Okay. Now coming to the histology, demyelinating changes predominantly affects the lateral columns. As you can see, these are the lateral columns, okay, and this is the posterior column. So it characteristically affects the lateral column and the posterior columns of the spinal cord. Microscopic examination shows a characteristic myelin pallor, okay, and destructive demyelination. Now, what is hypoxic ischemic demyelination? Brain tissue generally undergoes necrosis rather than demyelination in response to hypoxia or ischemia. However, very rarely you see hypoxia precipitating a myelinating oligodendrocyte loss, and that results in a characteristic hypoxic ischemic demyelination. Now, demyelination can occasionally occur at the edge of the neoplastic lesion as well. Okay, so especially in glial tumors, or rather malignant glial tumors or glioma, there is a characteristic zone of demyelination and a reactive change that is seen specifically in biopsy specimens. This can sometimes be problematic in small biopsy materials. Okay, therefore there is a note of caution here. So wherever you see a space occupying lesion in the brain and you can only make out demyelination, you better go back, okay, and see whether there is a zone of demyelination surrounding the tumor area and whether only the demyelinating zone has been biopsied or not. Okay, so to prevent any misdiagnosis from a small biopsy specimen, the tumor sample should be rebiopsied if there is any doubt. So, what are the take-home messages from this seminar of today? Make sure that you are aware of the clinical, radiological, and the laboratory features. Always think of demyelination, even with a space-occupying lesion. Multiple sclerosis can present as a space-occupying lesion. Even the acute disseminated encephalomyelitis, or ADEM, can precipitate as a space-occupying lesion. As multiple sclerosis is the most common demyelinating disorder, it should never be forgotten. Demyelination is different from dismyelination, as dismyelination, the prototype of which are the leukodystrophies, which predominantly occur due to genetic mutations. Luxol fast blue may help in ascertaining myelin better. Okay, so Luxol fast blue is the stain which helps in ascertaining the myelin better. Viral and nutritional causes should also be kept in mind when diagnosing a patient with demyelination. That is, whether it is JC virus or HIV virus mediated, or for that matter it may be measles virus mediated, or there may be some nutritional causes like vitamin B12 mediated subacute combined degeneration of the spinal cord, or a rapid correction in the sodium levels resulting in the characteristic Centralpontine myelinolysis. Always remember, in case of small biopsies, histology may show features of demyelination in tumors as well, particularly at the edge of the tumor. So if the edge of the tumor is biopsied, okay, caution is for the pathologist. Okay, so always remember that there may be a zone of demyelination surrounding a gliotic tumor as well. Thank you so much for your patient hearing. We'll meet next time with WHO classification of CNS tumors, the latest updates. Thank you.